The United Leukodystrophy Foundation presents AMN, presented by Dr. Marc Engelen, Dr. Wolfgang Koehler, Dr. Stephan Kemp, and Dr. Deborah Renaud.
I think I'll start. But I'm sharing my screen already, but I don't see my screen. Do you see my screen? Yeah, there we are. Well, good afternoon, good morning, wherever you are on the planet. So the four of us, we will present on AMN, I think we will put it a little broader. We will also touch on some other issues of ALD. And I will start with an introduction on the biochemistry and the genetics, and then Marc will take over, and then Wolfgang will be next, and Dr. Renaud will see us around for questions. Okay. Yeah. So we will touch on biochemistry and genetics, clinical features, establishing a diagnosis, recommendations for follow-up, and some new insights in research. So first, we'll start with some basics. It's always good to you can't say it enough, you can explain it enough, the basics of ALD. So this is a cell with the nucleus and the genetic material. And that's also where the ALD gene resides, the ABCD1 gene. And this is this organelle here is a peroxisome, and this is where very long chain fatty acids need to be broken down. And the very long chain fatty acids are the fatty acids that build up in ALD. So these fatty acids, they are made by the body itself through a process that's called elongation. And you need very long chain fatty acids, but you do not. You need a certain amount of them. So if there's a balance between synthesis and degradation, and the ALD gene is involved in the degradation of these very long chain fatty acids, and a mutation in the ABCD1 gene results in a defect in the ABCD1 protein. And therefore, a defect in the import of very long chain fatty acids into the peroxisome. So they're not degraded anymore. And as a result, they build up, and there's a storage of very long chain fatty acids in the cell, and ultimately in organs and tissues. And this is actually what was found out already in the late 70s. And the team of Hugo Moser, they use this knowledge, the storage of very long chain fatty acids in the body, to set up a screening assay for ALD. So here you see the levels of very long chain fatty acids in plasma. In green, the controls. In blue, the males, and in red, the females. We come back to the females later. But as you can see, all males have elevated levels of very long chain fatty acids. So this knowledge enabled people to screen for ALD. So ALD is caused by mutations in one gene, in the ABCD1 gene. And this is a very complicated slide, so we won't go through it that much. But the problem with ALD is that there are very many different mutations. We already have a database that holds over 850 different mutations. And all these different mutations, they cause ALD. And what we know currently is that all ALD patients have a mutation in the ABCD1 gene. All males with ALD have elevated levels of very long chain fatty acids. However, 15% of women with ALD, so proven women with proven ALD, have normal levels of very long chain fatty acids in plasma. And we will come back to that later. What we also know is that the very long chain fatty acids, either we measure them in plasma or in blood cells or in fibroblasts, they do not correlate with phenotype. And what we also know is that the mutations in ABCD1 do not have any predictive value with respect to the clinical outcome of the disease. So identical mutations are associated with the different phenotypes of ALD. And that is shown here in this is a study from Johannes Berger from 1994. They described a family with 7 affected males, and so these are all brothers. By definition, they all have the same mutation, but one individual developed AMN, two boys developed cerebral ALD, one male developed cerebral LD as an adult, and the other individual only had adrenal insufficiency. So what we know, to sum this up, we know that ALD is caused by mutations in the ABCD1 gene, and that results in a buildup of very long chain fatty acids. So, however, we can already establish that at birth, but we cannot predict which individual clinical path an individual will follow. So patients can develop adrenal insufficiency, cerebral LD, or as adults, spinal cord disease or myelopathy. And this is also the phenotype that many of the women will develop, and we'll also go into this later in the presentation. So I think this is already my final slide. So again, I already mentioned this, but what we do know is that the mutation ABCD1, the default mode of the disease is adrenal insufficiency in males, and spinal cord disease in males, and spinal cord disease in females. And there are other factors besides the mutation ABCD1 that play a role in whether an individual will develop cerebral LD. So we've been looking for these other factors, and this is a paper that came online last week. This is a large study that we worked on with several groups in Canada, in Amsterdam, for 4 years, trying to hunt for this modifier gene that would enable us to predict whether an individual would develop cerebral LD. This is a lot of work. Basically, we didn't find the modifier gene, but we more or less proved that there is no modifier gene. So there's not a single other gene or other environmental factor that would allow us to predict the clinical outcome of an individual. And I think that's also important, because we thought this was the case, but now we know it more or less for sure. And now I'll leave it for Marc. Marc, shall I run your slides?
That would be great. Thank you.
Super.
All right. So now, the next part of the presentation will look in some more depth at the clinical features of adrenal leukodystrophy in adults. And first, we start with adrenal failure. And as many of you know, adrenal failure, if you don't screen for it, gives symptoms that are very difficult to detect. The initial complaints are usually vague, like fatigue, abdominal pain, not recovering well from infections, and only in a very late stage do more recognizable symptoms occur, like pigmentation of the skin, as is shown in these pictures. This could be somebody who has been to the beach a lot, but if this happens in a country like the Netherlands in winter, then that is definitely a clue that there's something up. But this unfortunately is in a very late stage. And adrenal failure occurs in a lot of male patients. And on the graph on your top right, you can see the incidence increasing with age. So you see that it affects even boys. In about 50% already has adrenal failure at age 10, and then it gradually increases during life. But interestingly enough, there's a small subset, about 15 or 20% of men, who never seem to develop adrenal failure and stay asymptomatic, at least with respect to the adrenal functions late into life. Can I have the next slide, please?
Oh yeah, that's me.
Yeah, that's you, unfortunately. Yeah. Strangely enough, I think that Stephan made abundantly clear that there's a lot we know about ALD, and also a lot that we do not understand. And one of the strange things is, why are some tissues so affected in this disorder and others not at all? And even within the adrenal, there's different layers of the adrenal cortex that make different hormones. The inner part of the adrenal is not affected at all. The part that makes the hormones that are important for instance, salt retention, are generally also preserved. And only the one that makes the stress hormone, the hydrocortisone, is affected. So many people with adrenal failure due to ALD only need the hydrocortisone suppletion. And most people with adrenal failure due to other causes, like autoimmune Addison's disease, need both hormones. So that's just an interesting little fact. Can I have the next slide, please? All right, and I'll briefly touch on cerebral ALD because that is something that Dr. Koehler is going to talk about in more detail. But cerebral ALD is a leukodystrophy, so those manifestations affect the white matter of the brain. And when it occurs, it is generally rapidly progressive, in contrast to many other manifestations of ALD that develop over years or decades or even longer. The symptoms of the leukodystrophy develop over months to a few years. And not all men with with ALD are affected. We estimate that the risk to develop it is about 60% over life. But one thing that we've been more alert about is that it does occur in adulthood. It was originally considered a childhood form of the disease, but cerebral ALD does affect adult men also. Also, if somebody is not known to be affected by ALD, the early symptoms are difficult or impossible to recognize because they can be subtle behavioral or cognitive problems that are usually attributed to stress or other psychological factors, and only later in the disorder does it become clear that it is actually something affecting the central nervous system with weakness of the limbs or epileptic seizures. And if not treated, it is usually relentlessly progressive and causes severe disability and eventually death. Can I have the next slide, please? So how does it manifest? Well, on an MRI scan, but I'll leave most of it for Dr. Koehler, but you can see that the white matter, strangely enough, on these MRIs normally looks kind of grayish. And you can see on these MRI scans, you can see these big white areas, and that is the affected white matter, that is the leukodystrophy. And in about 20% of cases, it starts anterior and at the foreside of the brain, but more usually it starts in the back. And in adults, it can also start in other places. And pretty typical for adrenal leukodystrophy is that if you give contrast fluid in a vein, that you can see the contrast fluid on the scan. That is called enhancement, and that is a hallmark of an active progressive lesion. And especially in adults, it is important to realize that this enhancement can be very subtle and easy to miss if you don't give enough contrast and if you don't wait long enough before you perform the scan. And I have to admit that on this scan, actually, I think in the presentation, it's hardly visible. But I suppose that is the point, that you really have to look for it.
I see it.
Excellent. Next slide, please. Okay, and this is an example of cerebral ALD in a young boy, and you can see that it's that if untreated, it will progress through most of the white matter of the brain, and you can also see that the contrast enhancement in these rapidly progressive cases is much clearer and hard to miss. Next slide, please. Well, one thing that we did realize about cerebral ALD, that of course originally it was considered that once it started, it would always, relentlessly progress. And what we've seen over many authors have described over the last decades, that sometimes it seems to stop spontaneously without intervention. And then it can stay stable for years, but it can also happen that after 3, 5, 10 years or even longer, it reactivates again and starts progressing again. And we think that this arrested cerebral ALD is probably not very rare. But that's an observation we've made recently. And that makes, that's still very mysterious what then triggers it to activate and what triggers it to spontaneously arrest again. Next slide, please. Right. Well, now the core symptoms of adrenal leukodystrophy in adult men and women is the spinal cord disease. And this spinal cord disease is caused by progressive loss of fibers in the long tracts. And And the main tracts that are affected are the ones that are colored blue on this this picture. And these so-called dorsal columns are very important for position sense of your joints. So if these tracts do not function properly, you will not feel the position of, for instance, your ankle. You will not feel the position of your knee joint. And you can imagine then that makes walking very difficult, because your body does not feel how the feet are positioned, and that makes it easy to trip and to fall. And that symptoms is what neurologists call sensory ataxia. But also the motor tracts are affected. Those are the red, the tracts that are, oh, no problem. The tracts that are colored red in this picture. And these control the contraction of the muscles. And if these tracts are affected, the muscles become stiff and unresponsive and weak. A phenomenon we call spasticity. And this combination, the sensory ataxia and the spasticity affecting the legs, causes a gait disorder. And yeah, this is the core symptomatology that virtually all men and women will eventually develop. And also a point that is not something that gains much attention, but it's remarkable, is that men with ALD, they tend to have the normal balding type of the normal balding that affects most of us men, unfortunately, but much earlier, because the man on this picture is only 22 years old at the time of this picture. And of course, nobody would be surprised if you were like 45, but this early balding and thin hair is something that is very remarkable. But of course, compared to all the other symptoms, not something that is causing major problems. Can I have the next slide, please? So this is a graph that shows how these symptoms develop over time. This spinal cord disease is not something that affects children or boys or even rarely adolescents, but you can see that as you get older, men with ALD, they have a higher likelihood of being affected by this spinal cord disease. And above 50 or 60 years, it is exceedingly rare not to have overt spinal cord disease. But this being said, there is an enormous variation. There are those who are severely affected at 25, and there are those who still go jogging at 55. But on average, in the clinic, you see that people around 35, 40 are usually significantly impaired. All right, can I have the next slide, please? Great, right. Well, what is, of course, important is that you try to quantify this, because if you want to study a disease with the goal to develop new treatments, you have to be able to measure disease severity. And although although we've known about symptoms of spinal cord disease for maybe 120 or 130 years, it's still very difficult for us to quantify it, to measure it. And all the tools that do exist have severe limitations, as I'll try to illustrate based on this table. I'll not go into the details of most of them because it doesn't, but I think the 6-minute walk test is a nice example to illustrate this. A long time ago, somebody decided that a good measure of function would be to ask somebody to walk for 6 minutes and then measure how many meters have been traveled. And of course, you could say, well, that's if you repeat that every year, and you can measure something. And we also did this for adrenal leukodystrophy for a big group. And we saw that although you can, with this technique, measure the disease progression, changes are very small. As you can see in this table, the change for the entire group, so that includes hardly people who progress slowly and people who progress rapidly, it's all, everybody put together. On average, the group decreases 20 meters a year on a total distance of more than 400 meters. So that's a tiny difference. So that is good news, because that means ALD, the spinal cord disease of ALD, is a slow disease, which is good, of course. But on the other hand, you can also see that it makes it difficult to measure change. And also the 6-minute walk test, you can imagine that it's not specific for ALD. So if you, for instance, and this really happened in our studies, if you have a painful toe, or if you break your ankle, or if something else happens that is completely unrelated to ALD, it will completely, then that means you can no longer do an assessment. So preferably we would have other tools that are more specific and more sensitive. Can I have the next slide, please? So before we go into those new tools, we can summarize what we've just discussed. If you have adrenal leukodystrophy, then you have a mutation in the ABCD1 gene, you accumulate very long chain fatty acids, and the symptoms you can develop will be, well, spinal cord disease in adulthood, highly variable. You could develop cerebral ALD if you are a male patient, but not everybody develops that, and we are unsure about what triggers it. And if you are a male patient, it is probable that you will develop adrenal insufficiency. Can I have the next slide, please? Yeah, thank you. And this is basically the same, but then also with age factored in. As you can see that if you have ALD, you're always completely asymptomatic at birth, and then symptoms develop. Adrenal insufficiency, often in early childhood or early in life, the spinal cord disease later in life, and cerebral ALD, well, if it develops, often early in life, but it can be later. Next one, please. Yeah, and we put in some slides on women with ALD, because women are definitely affected, but the disease is different than in men. Women do not, only very, very, very rarely develop adrenal failure or cerebral ALD, but they do develop a spinal cord disease. Progression is slower in women, over decades and not over years. But you can see, and it also occurs later in life. And you can see that young women under 40 are hardly ever symptomatic, but over 40 and especially over 60, there's a high probability that there will be some degree of spinal cord disease. Can I have the next one, please? Thank you. Yeah, this slide is just to illustrate the EDSS score is a measure to score how abnormal the neurological examination is. And we use this tool for many disorders to quantify neurological examination and to determine if somebody is symptomatic or not. And we did this in women with ALD, and well, the EDSS score runs from 0 to 10. And over a period of 8 years for the entire group, there was an increase in EDSS score of 0.75 points, which is not a lot. So this is to illustrate that ALD is extremely slow in women, which is good news, of course. But as we will touch upon a little bit later, that makes it very difficult to do clinical trials in women. So that is why women are so often excluded, not because they don't have symptoms, but simply because we are not capable of measuring disease severity in women. Next one, please. All right. Now, briefly, how do you diagnose ALD? Well, in the late 70s, early 80s, it was discovered that these very long chain fatty acids, especially C26.0, accumulate, and this was developed into a highly sensitive and specific test. And nowadays, of course, in modern times, it is always complemented by genetic analysis of the ABCD1 gene. And also, that is, we repeat it every time, if you simply do the C26 test, you can miss the diagnosis in a woman, because about 10–15% of women have normal C26 levels. But of course, you can always confirm it with the ABCD1 mutation analysis. Can I have the next one?
This one.
Oh, sorry.
This is about the women.
Yeah.
We can skip this one. This is the 15% that have normal. That's the orange circle here.
Right.
And that's, of course, is the problem. This could be a false negative.
Yes. And then,
So.
and then I don't know if you picked it up, but there was a question added. What happens if you have a woman with complaints, with signs that you think, well, this could be adrenal leukodystrophy, but the very long chain fatty acids are in the normal range, and you find a change in the ABCD1 gene sequence,
like this one.
This is the correct one, I think. But if you find a change in the ABCD1 gene, but you don't know if it's a variant or a pathogenic mutation, and this is something that we've struggled with the past couple of years, but recently, and you can see the paper is out now. It's been going around for a few years that there are other markers in plasma, C26 lyso-PC, so that's a complex lipids with C26 built in, and this one is actually virtually always increased also in women with ALD. So now we have a marker that is better, and that will prevent those difficult situations in which you have diagnostic uncertainty. Next one, please. Yeah, and right, the United States was the first country in the world where newborn screening for this disorder was implemented, and Stephan made a very nice map to show that it's going well. There are many states who are now screening, and they actually use this C26 lyso-PC for the diagnosis. Next one, please. Yeah, and the Netherlands will also start, hopefully, screening for ALD, and that's a very long story, but we will only screen boys. And for those interested in how that will be accomplished, there's this paper that is freely accessible, and I think that there was also a specific session on the ULF on this specific subject. So
2 days ago.
Yeah, exactly. So we'll skip over this. Next one. Yes, please. Right. And this introduces new problems because, traditionally, of course, we see something in clinic with symptoms, and we put them in a follow-up protocol. But now we will get a new population of, well, I'm not even sure the term patient is appropriate. We will get people who are asymptomatic, but who have an ABCD1 mutation, so who are at risk of developing all kinds of complications. So we've been thinking about how we will screen those babies in a rational way. And that is also something that is, for those interested, please review the SCAN paper. Can I have the next one, please? So I have to hurry up a little bit. And so what is generally recommended, of course, this is not a law of nature. This is something that many people do, but of course, how this is specifically implemented depends a little bit on where you live. But for male patients with ALD, you need follow-up and endocrinologists. And as Wolfgang will speak on in more detail, we also think that MRI surveillance is mandatory. Next one, please. Yeah, this one I'll skip over because that will be covered by the next speaker. Yeah, just one little thing. The stem cell transplantation is a great treatment for cerebral ALD, but unfortunately, it seems that it has no effect or potentially minimal effect on the progression of the spinal cord disease. So that is really a different aspect of the disease. So stem cell transplantations, it modifies the disease, but it does not cure it. Next one. Okay, so to summarize, the myelopathy of adulthood, unfortunately, there's no disease modifying or curative therapy at this time. There is supportive care only. The adrenal insufficiency is, of course, easily treated by medication. The disease is progressive, but it's a very slow disease, which is good if you're affected by it. a challenge if you want to do a clinical trial. And the good news also is that there are many, many trials planned, and one actually ongoing for disease-modifying treatment. So there's a lot of interest in getting treatments for ALD patients available within the next few years. Can I have the next one, please? So now for a few minutes, I'd like to illustrate how difficult it is to do clinical trials for this disease, because it's slow. And because it is slow, it means that if you want to see a change, you have to build in a very long observation period. And trials that take 2 or 3 or 4 years are just a logistical nightmare and very expensive to do. And also, the 6-minute walk test is currently the most important outcome measure that is used in this kind of disorder. But you can also, that means that you cannot include all patients in your trials. For instance, if you're wheelchair bound, there's nothing to measure. Or if you're completely asymptomatic also, it's very difficult to see change. And because these measurements also have a high variability, they're not very accurate, you need even more patients. So all these factors are bad, but especially bad in a rare disease if you have a limited pool of patients that you could invite to participate. Can I have the next one, please? So what do we need? We need better, very sensitive, which means can detect small changes, non-invasive tools to measure myelopathy. Because the 6-minute walk test, if you do a little math on it, it means for a 1-year trial, you would need 226 patients in your treatment group and 226 patients in your placebo group. And not just any patients who are affected, who are on the cartoon kind of in the middle area. So there you go. That means you would probably need to do your trial on the entire planet, and you could only ever run one trial at a time. So this will really slow down treatment development. And women are not eligible because it's so slow in women that you would need to wait 5 or 8 or 10 years with this tool. So we need something better. Next slide, please. And there's lots of ideas, of course, going around, not only in the ALD field, but in other fields. And you can use new MRI techniques to measure the integrity of the long tracts. For instance, DTI is one of those techniques. And there you can show that in affected patients, the red bars, these parameters in the spinal cords and in the motor tracts are different. And you can also see them change over time. And it is our hope that with longer follow-up, that these measurements can replace the other tests. And these measurements you could also do, for instance, on somebody who is minimally symptomatic or who is in a wheelchair, and it will not be affected by how somebody feels on the day of the testing. If you have a cold, you will walk less meters, but the MRI scanner will just do an objective measurement. So this is something we hope to implement within the next few years. Can I have the next one? Well, optical coherence tomography is a very fast, painless technique with infrared light that measures the thickness of your retina. And the idea is that if you lose fibers in your spinal cord, that is also reflected by losing fibers in your retina. And the retina is easily accessible and can be measured by OCT. And we also could show that the thickness of the retina correlates with the severity of the myelopathy. And next slide. Thank you. We could also show that, especially the red bars, that this gradually changes year after year. So we also hope that in the future, this is one of the tests that could replace the traditional tests. Next one, please. Well, this one, you can imagine that if you lose fibers in your long tracts, that your spinal cord gets thinner. You can see in D, you can see the spinal cord's a nice oval. And you can see E is somebody who has spinal cord disease for decades and who is severely affected. And you can see that the spinal cord is obviously thinner and flatter. And if you quantify that, that is the graph on the right. So you can see that people who are symptomatic have a thinner spinal cord. And this is something that you can also use as an outcome measure. But unfortunately, Although it probably has some value, it also takes many years for you to register change. Over 2 years, you see virtually nothing. So this is probably not a good outcome measure for short clinical trials. Can I have the next one, please? Right. Well, this is something that was pioneered by the Kennedy Krieger Institute. They've been doing this for years. And like we talked about the sensory ataxia can be quantified by asking somebody to stand still and closing his or her eyes. And if you close your eyes, everybody will start to wobble a little bit. But if you have a sensory ataxia, you will wobble more. And the force plate is something that can quantify that wobbling. And this might also be a very good way to determine disease severity. And this one does seem to change pretty rapidly over time. So this is something that we will probably also see more and more in clinical trials. And next one, please. Right. Now, this is, I think, almost the final slide. It would also be great, of course, if you could just take a blood sample, measure something, and get an idea about disease activity. And this is a graph. If you and let's see, I think we only have to look at A and C. There's a little protein called neurofilament light, and that is released into the bloodstream if neural cells are damaged. And it's been used in Parkinson's and in Alzheimer's, MS, lots of neurological diseases, and in ALD also. Men more than women, it is increased in the plasma of people with ALD, especially people with ALD with spinal cord disease. So maybe that is also something that in the future we could use, because if you have an effective treatment, you would hope it would normalize. The next one, please. Yeah. So yeah, all the people in the picture that contributed to all the data you just saw, and all the people who have funded us. And next one. Yeah, now we switch to Wolfgang. Thank you for your attention.
I will stop sharing my screen, I guess. Oh, that's, well, where's my my mouse?
So, hello everybody. I'm a bit unhappy that I cannot be with you and talk to you personally this year, but maybe next year we'll have a personal meeting once again, and I really hope so. So I want to talk a little bit about hemopoietic stem cell transplantation or bone marrow transplantation in cerebral XALD patients, because I think this is quite important for some of you. What is stem cell therapy? I mean, this is a already established therapy since many years. It's used in leukemias and other diseases. And what you need for that is a so-called HLA identical donor, which is usually looked for in the family. So we're looking for a family donor first. But if there's no donor in the family, you also can go to registries and look for a donor which is feasible for that transplantation. Those donations are anonymous, and there are many sources where you can get the donor, the stem cell from. It's not only the bone marrow. You can also, in the meantime, you can harvest them from peripheral blood, like you can see here in this patient, in this donor. The blood is taken and put into a machine, a so-called apheresis machine, which then separates, looks for the cells that we need, which are the stem cells. And in the meantime, the patient needs to be preparated for this donation. And this is part of the problem, but we have to destroy the blood-forming cells, that's in the bone marrow of this patient, and to open a space that we can use then for the new stem cells, which are simply injected from the donor into the patient. So the stem cells are very immature cells. So they can resolve themselves to use themselves, but they also can differentiate into different tissues. In our case, we use this situation to differentiate these cells, or we use certain cells that differentiate into tissues that are defect in the disease. So we transplant healthy new tissue. Well, where's it used? You already heard a lot about X-linked adrenal leukodystrophy, and of course, most people in adulthood have the myelopathic form, which is the AMN, but up to 5% primary in adulthood develop a very similar disease like you usually see in childhood disease, which is called adulthood cerebral ALD. And more important, a big proportion, I'm not sure it's about 60%, but up to 60% of patients who had previously AMN, or maybe over years, maybe over decades, can develop inflammatory disease, which is shown here in the MRI. You already seen these MRI with contrast enhancement. And there was a question, I think, from Brad about the technique. Yes, you have to wait a little bit, at least 5 minutes, if you want to see the uptake of this contrast enhancement in the brain. It's even better to wait for 10 minutes, but this is up to your radiologist.
So there was a question for the first speakers: how long should they wait after the contrast is injected prior to taking the MRI scan with contrast?
Right. Yeah, that has never been systematically studied, but we've seen a few adults with slowly progressive diseases where it took up to 5 minutes after contrast injection to be able to see enhancement. And I know sometimes in oncology, they just wait 1 minute. That's not enough. 5 minutes at least, preferably 10. Okay.
There was a question that says, what is the recommended treatment once AMN starts in a man who is in his 30s?
Well, if for the spinal cord disease, I presume, because that is usually the age at which that manifests. Unfortunately, we have no curative treatment, and we cannot slow the disease down at this time. But what can be tremendously helpful is to send them to rehabilitation medicine, who have programs to make sure that you can function well. So that is, I think, very important, to go to rehabilitation management for optimal spasticity treatment, etc.
Okay.
We're back.
We'll go back to go ahead.
Oh yes. Okay. So if you have the AMN, it's progressing over the decades. But if you have the cerebral ALD, it's progressing over months. And the problem is that one is going to the other form. So I give you some examples here. This is a patient with a primary adult cerebral ALD. So he starts with some early mood changes when he was 27, when he was a PhD student. He was completely normal until that. Up to then he developed a mild ataxia and these very early mood changes. And you see within a period of 2 years of time, he was completely demented and in a severely disabled situation. This is in contrast to the secondary adult cerebral ALD. Here, an example of a 22-year-old male who had spastic gait for many years and walking disabilities for many years, when he then suddenly developed some more progressive disease and some cognitive abnormalities. And at that point of time, the disease is progressing very much, and we have to put this to determine this point of time, because this is very important when the cerebral disease starts. So you have already seen curves like this. These are Kaplan-Meier curves. These I need to introduce this to you. What you see here in over a certain period of time, you see various phenotypes: childhood, juvenile, or adult phenotypes. When they get some symptoms or an event, and you see the progression of the disease once the curve is going down. So these are curves from Dr. Hugo Moser, which is the natural history of cerebral disease. So it doesn't depend when it occurs, in childhood or in adulthood. It's always a very severe disease, which is rapidly progressing over a short period of time, let's say 2 to 3 years, until severe disability occurs. And this are results from children who are treated with bone marrow transplantation. And you see in the blue line here that it is possible to stop this progression downwards by bone marrow transplantation. We know this situation for many years, but we didn't know if this already also is true for adults. So a couple of years ago, we started to treat adult cerebral patients also with bone marrow transplantation or stem cell transplantation. These are current results in about 20 patients who are already treated with this treatment. What you can see here in these 3 curves is, if you look at the first curve, that there is there's still a progression or going down of this curve, but then the disease stopped in terms of survival. And this all happens in the first year after bone marrow transplantation. But, you know, survival is maybe not everything. You already also may ask, how is my survival after this treatment? So we also look for the cognitive function of these patients. And indeed, there's up to the 2nd year, there is some progression in some of the patients, but you also can see that at least 50% of the patients are completely stable after this 2nd or 3rd year after the treatment with hematopoietic stem cell transplantation. So there, we're also asking, are there some conditions before treatment? Are there patients who do better after treatment? Yes, and indeed, obviously, if you have less symptoms before treatments, let's say if you have an EDSS under 4, which is that you are still able to walk independently. So we have a 100% survival. We have 100% preservation of cognitive stable survival and event-free survival for long term. So it really depends on how is your situation before treatment. When you start treatment, it determines the outcome. Or say the other way around, it's extremely important to detect the cerebral involvement as early as possible. And this is the same situation like in the childhood disease. If we can start with the treatment as early as possible in a situation where you're still able to walk independently with minor neurological symptoms, with no cognitive deficits, but already with starting cerebral inflammation, at that point of time, there may be the best situation to treat and the best outcome versus other situations. So to summarize this, I think it's important to say that you have, for this treatment, you have to have a confirmed inflammatory demyelination, and we usually use the gadolinium enhancement in the MRI to prove that this is cerebral inflammation disease. And a favorable outcome or favorable conditions with a high likelihood for a beneficial long-term outcome are minor or very mild or moderate motor symptoms, mild or no cognitive dysfunction, mild bladder and bowel dysfunction. So if you are in an early stage of a cerebral disease, then you have a really good outcome with this disease. So there are other criteria for example, MRI criteria or transplant criteria, which also need to be looked at for long-term outcome, but I want to go into much detail about this because we need some time maybe for the discussion. So I summarize this treatment is really for adult cerebral in an early stage, a life-saving therapeutic option. It is able to stop the demyelination, to stop the inflammation in most of the patients. And we have currently very good techniques to do this treatment with low complications, with low graft versus host disease. But of course, we had to pre-select very carefully which are the feasible patients for this treatment. And of course, we need more information. And for this, I'm very happy that the ULF sponsored an international group which is cooperating on the long-term outcome of all treated patients with stem cell therapy in adulthood worldwide. So we will get from this registry, we will get more information about the preconditions which patients are the best to treat with this treatment. So thank you for your attention.
Okay, thank you. So I'll quickly take a question. There was a question about what is the rate of sexual dysfunction in men? And on Thursday, when we presented the research summary for the survey-based natural history study, 78% of men said they had erectile dysfunction or sexual dysfunction. There's a question for you, Dr. Koehler, about whether bone marrow transplantation can be used in men with AMN to prevent cerebral involvement rather than to treat cerebral involvement.
No, we wouldn't do that because the risks are definitely too high. So we have a, let's say, 10 to 15% mortality rate. So it's a high risk therapy. So you only would treat a patient who is at risk to die from the disease with a high likelihood. And in this situation, you take the risk for a bone marrow transplantation. So we are currently not treating AMN patients with stem cell therapy.
Okay. There's a question about people to share preliminary results of studies related to larigiltazone in patients with AMN.
Yeah, I can be very brief on that. There are no preliminary results. It is expected that all the data will be analyzed in October of this year.
Okay. And then about dimethyl fumarate, is this an option for patients with ALD?
Now, I read the question in the comments. Yeah, theoretically maybe, but as far as I know, nobody is at this point working on getting a clinical trial started with that compound.
Okay, and then what about treating the mitochondrial component with cofactors like one would treat a mitochondrial disorder?
Yeah, we only have a few minutes, so I have to be very brief. You know, these are all theoretically very nice concepts, but the reality is that we don't really understand the mechanism of the axonal degeneration in ALD. And of course you see all kinds of mitochondrial dysfunction, but you don't know if it's primary or secondary. As I would say, this is all still very preliminary. And the difficult thing is you can come up with all kinds of ideas of compounds to test. But like we said in our presentation, to actually prove that it works, you need a very complicated and expensive clinical trial. So before you take that step, you need to put a lot of thought in it, whether it's worth that kind of effort. You only want to do a trial for treatments that are very promising.
What is the rate of occurrence of AMN in men who were transplanted as boys?
Well, we currently, I have an overview of about 35 children who are treated with bone marrow transplantation in childhood, and none of these had a recurrent cerebral disease yet.
No, but I think the question was the spinal cord disease.
Yes, spinal cord.
Developing AMN, and I believe it's the same as other.
Yeah.
No, it's not.
Yeah,
Go ahead. Answer, please.
It's not the same. We are working on these 35 patients right now, trying to see them in adulthood. It's a large group of patients, and it looks like in the moment that the transplantation is also kind of amelioration of the AMN, but it's not fully preventive.
Yeah, I'm a little less optimistic. What I can say, we have a few patients that were transplanted as boys and who now in adulthood have clear spinal cord disease.
Yeah, but it's only a few patients. And it's,
but it's 3 out of 5. So
so whether if it, but if, like Wolfgang said, if the disease progression is slower, is of course something that is very difficult to prove or disprove. So maybe. Yeah.
Okay.
And indeed, that adults that are treated with bone marrow transplantation up to the 5 or 6 years, we don't see any progression over AMN yet.
Yeah, and this question hasn't been asked by anybody, but I think it's important. Is gene therapy a feasible option for men who develop cerebral disease if they don't have a bone marrow, don't have a match?
Sure. But I can't get the gene therapy now currently. But I'm asking for that. Yes, we are treating children with the gene therapy, very successful, and of course we also want to treat the adults. Yes, with cerebral disease, but it's not available yet. Yeah. Yeah. And maybe one additional remark. It's we are really talking about cerebral ALD with the gene therapy. So we don't have gene therapy for AMN yet. But of course, this is Florian Eichler, for example, is working on this very hard. I think maybe we'll have that in the near future. I hope we will have this in the near future, but it's not there yet. Yeah.
That's right. And for, I guess, the American patients, the men that are wondering, Dr. Lund at the University of Minnesota is doing transplantation for adult men with cerebral ALD.
Okay. Yeah.
Dr. Lund is on in the next session. So
he's on in the next
if people want to watch the next session, they can ask him personally.
That's right. So I want to give them.
Well, Deborah, there are several centers who are treating with stem cell therapy in adults. But all of these centers are connected within this group and the registry. So we are really working together to find the best way how to treat adults with cerebral ALD as well.
Yes, but I want to introduce the fact that Dr. Lund is speaking in the next session, and so
very good.
I know of the wonderful group that you're leading, Dr. Koehler, that international group for patients with cerebral ALD. It's been wonderful.
Okay.
Okay, I think our time is up now. Thank you everyone for joining us, and in particular to our speakers this morning.
Well, thank you.
Yeah. Yes, thank you to all of our speakers for this morning. We apologize for the technical difficulties. We stumbled through it though, and we were hopefully able to get to everyone's questions. So if you do have any additional questions for the speakers that you felt weren't addressed today, please feel free to shoot us an email at office@ulf.org, and I'll pass it along to our speakers and see if I can get them to reply for us. Otherwise, we do have the ALD session coming up in about a half an hour. So we're going to go get ready for that, and we'll see everybody hopefully in Chicago next year.
Sounds good.
Bye-bye.